Think Forward. Think Research Channel.
So I'm Jim Hoxie. I'm director of the Penn CFAR. It's a great pleasure to welcome you all to this long-awaited event. 2 years in the planning. So for those of you who are new to the CFAR experience, each year CFARs host, our CFAR, a CFAR, hosts all of the CFARs across the country. It is the scientific meeting is the prelude to our business meeting where a number of policy issues are addressed in the CFAR network, where we are informed from NIH what we need to be thinking about. But all in all, this is a time that is really energizing for all the CFAR directors, their administrative staffs, and we've really looked forward to hosting this meeting for a long time. CFARs, I think, first came into being in 1988. They have grown, matured, evolved as the epidemic has evolved. And each year we ask ourselves, what can we do and how can we do it better? At present, the current CFARs that are funded by NIH are shown here. They all have representatives who are here, not just the directors, but also their administrative teams. And again, this is a time where we are really looking forward to engaging discussions with each other and with NIH. In a nutshell, what CFARs do is summarized in this slide, and I've taken just a couple of bullet terms from our mission statement, and I think it really is important just to comment on a few of these things. So first of all, with regard to research, the buzzwords are that our research covers really the whole gambit of work in HIV/AIDS. It's basic clinical, it's behavioral, it's translational, but it needs to be innovative, interdisciplinary, and most important, collaborative. We also have, pressing the button, educational missions within our CFAR and particularly importantly within our communities. We have, as the epidemic has evolved and exploded in the international scene, we have an international mission to strengthen the capacity for AIDS research in developing countries, but as is equally important, not to lose sight of the continuing epidemic in our community, where we have a responsibility to communicate knowledge, support prevention and treatment research, and to reach those people who are hardest to reach and hardest hit in our domestic populations. We have had a tremendous relationship with our community advisory board in this regard, and you will hear more about that. But in sum, basically what CFARs need to do is to add value to their campus. It's for each CFAR to decide what that value is going to be and how they're going to do it, and that's really where the creativity comes in pulling these centers and groups of people together. Borrowing logos from the various websites of our CFARs, I show this slide really to make the point that certainly a theme of this meeting and in the last few meetings has been the importance of CFARs to work together, and we are looking harder than ever for ways to do that. I think there is excitement among many of us about how we can do with our various centers what we've been able to do on our campuses. So we are looking forward to a number of opportunities that will come from our organizations, which command tremendous resources, tremendous support, and investigators in bringing them together. So this meeting is basically 2 years or so in the making. I think for me it began with a tap on the shoulder from Jim Curran at Emory a couple of years ago, and Francisco and I took a long sigh, and then you go through a year or so of, I won't say denial, but sort of calm reflection. And then you go through about another year of angst, and then the energies build, and you think, what is the theme that you're going to revolve your presentation around? But you can't cover everything, but we've tried to cover a lot, and I think we're really excited by the critical mass of people that we've been able to bring here. We have a session this morning that will be focusing on vaccine. We have an important community perspectives talk. There is then an emphasis on Botswana. We have some of the leaders in the work that's been going on there. And then the issue of HIV-TB infection, a session I'll be chairing, will be coming. And then in the afternoon, we have some terrific basic science themes, viral genes at the cutting edge, and then viral host interactions. So it's a program we're really proud of. So you don't pull something like this together without a lot of help, and a sincere thanks needs to go out to a number of people and organizations. First and foremost, the NIH, the Office of AIDS Research, the Division of AIDS, many people who have worked closely with us throughout the year and past years in communicating to us what we need to be thinking about, but also for the generous support of these meetings. It clearly could not happen without them. And importantly, this year, through the work of the University of Alabama CFAR and putting the grant in that came from NIH, we are able to sponsor 15 trainees to be able to attend this meeting. I also want to thank very sincerely our School of Medicine for their generous support, not only financially for this meeting, but also for the facilities and really working with us in step from the beginning to make this meeting a success. We have support from many pharmaceutical companies that I gratefully acknowledge in this slide. I want to especially thank our speakers who have come from as far away as Botswana and as near as the 4th floor of the Johnson Pavilion. That doesn't even come close to talking about the traveling heroics that many of them took to get here. London, Budapest, many. And where? The Schuylkill, yeah, let me tell you about it. Amtrak with its own special treats last night. But this day is about our speakers, and our excitement really is generated by their presence, their stature, and it's going to be just a fantastic time. And finally, internally, I want to thank my colleagues, particularly those in the CFAR Executive Committee, for their advice, their collegiality in pulling together this program. I want to thank our Community Advisory Board, who you will hear about later on this morning, for the partnership we have forged with them and the way that they have sensitized us to important issues. And again, we're pleased, very pleased to give them a part of this program. And to my colleague, friend, and co-director, Francisco Gonzalez, who has been slogging away with me in every CFAR issue that has come up from the beginning. It has been a tremendous working relationship, and Francisco, I thank you for your constructive criticisms as well as your friendships along the way. And a special thanks to Julia, to Olivia, and to Evelyn. Faces you know, names that you know, but there are thousands of details that go into putting a meeting like this together. They have been here some longer than others, but we are very, very grateful to what you've been able to accomplish. And finally, just a comment about our own CFAR. We are a CFAR of 3 institutions, the University of Pennsylvania and all its schools, Children's Hospital, and the Wistar Institute. And it is an extraordinary campus to be able to have in one location these kinds of perspectives from clinicians, basic scientists, behavioral scientists. It's been a terrific group and really a wonderful environment for us in which to build our CFAR. And finally, as I now turn to introduce Arthur Rubenstein, our dean, I want to point out that we are often asked by groups who want to bring CFARs to their campuses, what does it take? And it really begins with institutional support. If you cannot demonstrate real institutional support for your center, you are not going to have one. And we have been very fortunate here at Penn, first with under the leadership of Bill Kelly and now Arthur, to have strong institutional support every step of the way. So Arthur, we thank you for your partnership with us, for your support of this center, and for helping to kick this event off.
Welcome everyone to the special program. I think almost every year that I've been here, 4 years, I've had the pleasure of interacting with a variety of programs that CFAR has put on, and I've been delighted each time. And this is, of course, a very special one, and so I want to welcome you here. I know many of you come from our campus, as Jim has said, Wistar, CHOP, and Penn, but many of you come from other parts of this country, Europe and Africa, and I want to extend a special welcome to you. The agenda for today's symposium, which I've looked at carefully, indicates the many important advances and also challenges that remain in HIV/AIDS. This is an important international problem and challenge, and dealing with it in this kind of cohesive way under the NIH umbrella is something that's very, very important. The title of this year's symposium also gives us hope, from innovation to intervention. Both of these words, I think you'll agree, have positive connotations in medicine and science. And when we speak of intervention, it is customary because we are confident that one in question has some chance of success. Certainly, it's a very far cry from the early days of this epidemic when there was a sense of hopelessness in terms of prevention and treatment. And now I think we're somewhere along in all of those areas, and that's very, very encouraging. The fact that we can host this event today is also something special. This university, under its new president, Dr. Amy Gutman, who couldn't be here today but asked me especially to convey her greetings to you, has made it clear in her compact that the goals of Penn in the future are to deal with things globally as well as locally, and to really engage in international challenges that we should be able to contribute positively to. And on her behalf, I just want to say these are the kinds of programs that she would hold dear, and as I say, she sends you her greetings. So I want to welcome you to our campus. I think today, as Jim and Francisco have put together with their colleagues, should be very exciting, and I know that you will have a good time.
If I were to tell my colleagues in the community that two rock stars, two very important white scientists, have learned to manipulate the cold virus, and they're working with DNA on HIV, it would be a very frightening conversation to have in the communities where I work. And I could spend the next 20 minutes telling you how to do that. I actually understood most of what Gary and Bart had to say because I get to sit in a lot of meetings and work on HIV vaccines with them and try to translate the science. But what I want to talk about this morning, and I'm from Seattle, don't worry, I will not keep you from your coffee. I will try to get you to your coffee. What I want to talk about this morning is that 46% is not acceptable. And I want to ask us, how did we get here? And that's a title, when you look at it, you say, how does that fit into a CFAR symposium? I'm hoping like when you go to a movie called, Proof or Prime or something, you figure out by the end of the movie how the title fits. But as of yesterday at 5 p.m., we had an epidemic that the numbers continue to overwhelm us. And I want us to remember that we have to deal with HIV as a virus, and we have to deal with it at a cellular level. But at a community level, we have to work with the people that are involved. Now, I want to thank the organizers, and especially the CAB here at UPenn, for inviting me to the birthplace of freedom, and for me, what's somewhat the birthplace of activism. And just want to remember people who I feel have been very important in the HIV movement. Tell you that most of you wouldn't have jobs if activists hadn't fought with Congress to make sure that we paid closer attention to HIV/AIDS. And that this is a place where Reagan first uttered the word AIDS publicly, right here in Philadelphia. you know. Bart and Gary talked a lot about HIV vaccines at a cellular level, but I want you to know the constellation of folks working on HIV vaccines is a large constellation of folks, and that in addition to this being the birthplace of freedom, Philadelphia is also the home of many biotech firms and companies who've done a lot of innovative research. And you know, some of that at a community level hasn't been very acceptable when they've told us what they've accomplished. So I'm hoping you at the CFARs think about how you talk about those accomplishments. If I were going to do a slide today that told you where my information comes from, I want you to know it comes from community. These are folks who will be on the phone in a couple of hours at our community advisory board for the HIV vaccine, our global call. And you know, one of the things that is part of the CFAR mission is promoting knowledge of CFAR research findings and the importance of AIDS research through community outreach. And so I want to thank Jim Hoxie. I want to thank and say that if he didn't have the support of the university here, he wouldn't be able to do the kind of community outreach. I don't know of other CFARs that have CABs that are as active as the Community Advisory Board here. I don't know of other CFARs that have community advisory boards that have an actual budget where the CAB actually has control over doing some of the research that they think is important. This is your chance to stop and think about what you're doing in your CFARs. I'm going to ask you to do some other things as we go through, but think about what you've done with your CABs. Now, some people would think this is a great time in HIV. We've got all of these different treatments to deal with HIV. When I go to the community, I go to that person under the age of 25, that translates into, I don't have to listen to what the behavioral scientists tell me. I don't have to be protected, have to use protection, because all I'll do is take some pills. You know, it's part of the CFAR's job to translate the science. You know, as we talk about HIV vaccines, we've learned a lot, as Gary and Bart pointed out in the last 5 years, and we've changed our strategies, and we know where we're going to have to affect HIV in the human immune system. We've got a lot of mechanisms for doing that. But at almost a quarter of a century into this epidemic, we're still looking at 60 million new infections, 60 million infections, 20 million deaths. And we've got a whole generation of people that has not known a world without AIDS. You know, and some of you would like to think of me as Wakefield, that community guy that goes to Africa, or that community guy that's been seen on the streets of Brazil, you know, or that hangs out with other African-American men who are working on HIV and AIDS, you know, and even sometimes hangs out with activists who are working on HIV and AIDS, you know. But I'm that community guy that when I stand and talk in front of you, you know, if there's a cute guy in the audience, my mind might go just slightly off of the science, you know. You know, I am that community guy that does things other than work on HIV. You know, I get to go to Disneyland like some famous rock stars. And when I think about shopping for Christmas, my mind goes someplace that most of your minds probably wouldn't go this morning. You know? But we are talking a very serious epidemic, and I do care about my colleagues, and I care about the new infections globally. And I was very happy this morning to have the emphasis on what's happening in the epidemic here in the United States. Because when I think about the United States, you know, if you turned on Oprah, she would have you believe that African-American women are the place we should turn all of our attention and all of our research. And I do care about the fact that the African-American women are disproportionately affected. But as I look at the data, I have to remember that for every African-American woman that I care about, there are 3 black men I need to care about. That blacks continue to be disproportionately affected in every one of our cities and in every one of the places where there are CFAR resources. Now, earlier this year, the Centers for Disease Control published in their regular report some findings from their behavioral surveillance work that they do. And they provided those findings about all of the cities, but they actually took a particular look at 5 of those cities and gave us prevalence rates for those 5 cities. And And that's pretty high prevalence among MSM. This is venue-based research. It's a very targeted and specific community. Now, when you go to expand your CFAR work to Africa, you do the kind of mapping projects we saw this morning. You do the kind of interventions where you spend time and you make sure you get your cultural anthropologist involved. You get your behavior scientist involved. You really say, how do we take the entire CFAR team and make a difference in Africa? I'm wondering if we've done the same thing here in the United States in terms of our MSM communities. Now, as we heard, MSM tend to be still the largest number of cases. As the CDC looks at syphilis and other diseases, and when we take the data across the whole country, we're still looking maybe at only 2% prevalence rates. But I was reminded a couple of years ago in some CDC data that younger African American men are at risk in very disproportionate ways. And as at the CDC conference this year, those 5 cities that I talked about, they presented the behavioral data where they went into those venues and they said, in those 5 cities, we're also going to do HIV testing for the people that answer our questionnaire. And I did that testing for that questionnaire, and there's a figure on here that disturbs me greatly, and that's this figure right here. And you're a scientist, I'm not going to take you through the whole chart. I'm not going to tell you the limitations of those findings, but 46% black. So I want to tell you, as Steve Wakefield, the community person, not Steve Wakefield, your colleague on an advisory group, not Steve Wakefield, your fellow board member for the City Board of Health, but as a community person, what that says to me. I look at the work we've done in the last several years to expand to global research for HIV, and I look at a place like at Swaziland where there's 40% seroprevalence, or Botswana, or South Africa even, where there's some studies that talk about 25% seroprevalence. And then I think black gay men, 46%. That's a number that's higher than any of those other numbers. Are we putting our resources into those communities? We have the infrastructure at our institutions. We have presidents and deans who go out publicly on a day-to-day basis and say, our institution is committed to the community and we're going to do the work to make a difference in our community. But are we doing the research? How many of you, just ask yourself, in my CFAR, how many projects are there today that target that one population? As we look at clinical trials, not just in HIV, but look at our treatment trials, blacks continue to be underrepresented. Latinos continue to be underrepresented in our research. The people that are easiest for us to do outreach to, the ones who we can use our historic outreach methods, are the ones who are involved in our studies. The myths and rumors about HIV continue to run rampant. The concern about Tuskegee, the concern, Gary talked about using guinea pigs. That information, when I say that this is what happened in guinea pigs, and I say, and by the way, we want to now stick this in your arm, doesn't get me where I want to go in the community where I work. There was another study earlier this year that just pointed out just a number of the myths and misconceptions that people have, and it's very disturbing to think that over half the people out there believe that the federal government, the source of your funding, has a cure and is keeping it from them. So I'm asking you to go back in those communities and translate the research, and to keep in mind that in all of those communities where you're going, there's the magic of Magic Johnson. Magic Johnson, the myth out there is that he's beat HIV. He does 24-hour fitness commercials on the West Coast on a regular basis. My community doesn't recognize often that the truth is that the scientific research that keeps Magic Johnson going on a day-to-day basis is the same research that you're doing in your CFARs. You're the ones that have the answer. So I'm going to ask you to take that information and go and do something different. I could spend some time on this nice, simple slide. We need to have community partners in research, and we've got to make sure we inform the community before the study's done, and we go back to the community after the study's done. And I will tell you that I'll spend at least an hour tomorrow with my community colleagues talking with them about their responsibilities in terms of the research. But I'm going to ask you to do something really different. When you get home, think about firing yourself. Just imagine Donald Trump sitting in your office saying, "You're fired." All right? If you don't want to do that, think, well, I have to have a retirement plan. I've been doing this a long time, and I'm tired. So fire yourself. Think about who else in your institution could do the work that you're doing. And what does that look like for me? Some of you have talked a lot about your mentoring, but as I look around the room, I see a lot of familiar faces. Think about as you mentor people, that you've talked to them about publishing a parish, but how many of you invited to be the co-author on that book chapter? How many times have you said, I can't accept the call, I can't accept your invitation to speak, but I've got somebody in my shop that could speak clearly on the work that we do here in my shop. You say, I can't accept it, but so-and-so at the next university might be able to be there, is our usual answer. Or, think about the person that you're mentoring and ask them, what could you do for them this year to move their career along? When you're at that big conference, I'm a longtime conference survivor. I know that if I want to go to CROI in Denver next year, I've got to register on Monday. A lot of community people don't know that. But you'll have people in your shop. Think about inviting them to go to dinner with you and the good old boys. Let them sit at that table and get to know some of those people who might steal them away from you and have them work in their shop. The second thing after I want you to fire yourself, I want you to think about building community scientific literacy. I work with a community advisory board where they can take this slide out into the community and they can explain it to the community and they can tell them how vaccines are constructed. Because what we've learned to do is have true partnerships between the scientists and the community members. Our recent CAB Train the Trainer retreat, we asked the laboratory persons to come in and explain the assays. We had 4 different types of assays that they explained. We asked them to put simple drawings on the board, and then we asked them to oversee the CAB members, teaching other CAB members about those assays, teaching them what an LA spot really meant and looked like, And some of them had to do it through an interpreter, through a foreign language interpreter. If they can do that, you can find the time to build those partnerships. Then the last thing I think I want to ask you to do is, I want to ask you to take a black man to lunch. We live in communities where there are black people that we see as leaders, and we've always thought he should be doing more for HIV, but we've never invited him to lunch. Tracy said the reason he decided to lend his image and to wear this bracelet was somebody took him to lunch and just had a conversation with him that his image, his impact on the community would be great. Talk to those people about the research you're doing and then make yourself available to do a luncheon or a meeting in their home with a few of their friends, or to go to their church and do an Ask the Doctor, or just to help a group of parents with talking to their kids about HIV. I've talked to you about the Magic Johnson abracadabra, and I'm not going to spend any more time on that because I'm not going to keep you from your coffee. But I want you to go back to the people you've done the research with. They provided their cells, they provided their blood products, they've provided their arms, they've helped us make the discoveries we've made about HIV. They've been in the long-term studies and the short-term studies. And the biggest complaint I hear from communities is we do the research and we disappear. We publish in the published magazines and we think we've done our job because it has appeared in the Journal of AIDS. You have not done your job until it has appeared in the local newspaper and you've talked about it on a radio or a TV show. We can have simple ways of talking about things. We don't have to talk about chimerics. Talk about abstinence, be faithful, use condoms. Talk about CNN, condoms, needle exchange and negotiation. Or even talk about research, microbicides, treatment, vaccines. Tell somebody that if they wear a condom, it'll protect them from HIV. But since you can't get people to wear condoms, You can't stop sex. We have some things that we're trying that maybe at this point are, well, in a couple of years we'll all be 1/3 effective and we'll lower HIV rates. But they won't understand that if you aren't the messengers. You've given a lot. If you work in HIV, you have given a lot. And I just want to ask you to give a little bit more in order to make sure that your CFAR is a place where these people can join me in saying, I'm proud to be part of the work that's happening in the institution in my neighborhood. Thanks.
It's a real privilege to be here today. I want to thank Dr. Hoxie and Dr. Friedman and all of you for attending today. I'm going to move quickly through a lot of information to acquaint those of you who in the audience who don't think about pediatric HIV/AIDS every day with some of what is going on in the developing world with regards to expanding access of children to care and treatment for HIV. And as you will see, the program in Botswana really has played an important role in this. This is an image that I imagine is familiar to any of you who have worked on the pediatric ward of an African hospital over the past decade, a wasted, dying child with HIV infection. HIV/AIDS is now the predominant cause of hospitalization and death in many of the southern African countries. 500,000 African children died of AIDS last year alone. That's the death of a child every minute of every hour, 24 hours a day, 365 days a year. Globally, HIV/AIDS now accounts for 4% of all child deaths, but in Botswana in particular, the subject of the program just now, UNICEF said earlier this year that 57.7% of all under age 5 deaths are caused by HIV/AIDS. So AIDS is actually killing more children than all other causes combined. Stephen Lewis, who is Special Envoy for AIDS in Africa from the United Nations, said in January, in the instance of antiretroviral therapy, the scenario for children is quite simply doomsday. Children are underrepresented among those accessing treatment in virtually every setting worldwide. In fact, across Africa, in the few places where adult treatment programs have been established, children frequently have been either excluded or definitely are underrepresented among those receiving treatment. UNICEF estimated in April that no more than 15,000 to 25,000 children worldwide were receiving antiretroviral treatment. That's fewer than 1% of all HIV-infected children globally. Well, what are the barriers? This is one type of barrier. The pharmacy window is 4 feet off the ground and the child is 2 feet tall, but that's not really the kind of barrier that I'm talking about. Certainly there's been an issue of lack of infrastructure. Children are not just small adults. They require special diagnostic strategies, as you know, particularly during infancy. The clinics for administering therapy to children have not existed, the laboratories and so forth. There's been a lack and loss of human capacity. The productive capacity of African professional schools to produce doctors and nurses and pharmacists and so forth is very low. There's been an exodus of professionals from the region to the developed world. This was the subject of an article in the New England Journal of Medicine just 2 weeks ago that I would recommend to you. And then there have been deaths of professionals from HIV/AIDS. It's been estimated that 50 to 60% of all deaths among health professionals in sub-Saharan Africa today are caused by HIV. There's the issue of prohibitive expense. Although the cost of the antiretroviral medications has come down to as low as $140 or $150 per year for triple therapy, certainly with countries having, some of the poorest countries having per capita expenditures on health of as little as $30, this is prohibitive, and it's particularly the case in pediatrics, where the pediatric drug formulations sometimes cost 2 or 3 times what the adult formulations cost. There's been a lack of political commitment to the treatment of children. When children are restored to health, they don't go back to work and pay taxes, and they don't vote. And then among health professionals, there's the perceived complexity of pediatric treatment. I hear commonly doctors saying, well, aren't the drugs too toxic for children? Aren't they too strong? Or we don't understand how to dose the medications for children. Well, our work in the care and treatment of children in resource-poor settings started very far away from Africa in Constanța, Romania, a decade ago, where I met children like George, who was 10 years old when this photograph was taken and who weighed only about 40 pounds. He was the size of a 4-year-old. and Alina, who also was 10 years old. These were children who lived and died in the orphanages in Constanza in the late 1990s without ever gaining access to an antiretroviral drug, this at a time when highly active antiretroviral therapy was transforming the health of American children. Ultimately, in Romania, we renovated an old orphanage that had been closed and completely abandoned for about 10 years. We renovated it and opened the Centrul de Copii Romano-American or Romanian-American Children's Center in April of 2001. This is the way the building looks today. And this center today is the largest children's HIV/AIDS treatment center on the European continent, far larger than any American or European center caring for children. There are about 620 children receiving antiretroviral therapy in the center today. And I could show you a lot of data about how the health of the children in Constanza has been transformed. But I think this one slide just about says it all. The center opened in April of 2001. The program of highly active antiretroviral therapy started in November of 2001, just at the tail end of the year. And you can see what has happened to the death rate, the annual death rate for HIV-infected children in Constanza. It's dropped from 12% to 7% to 3% to just 1% last year. In absolute terms, this is the difference between 109 deaths in 2001 and 7 deaths in 2004. Highly active antiretroviral therapy works as well in resource-limited settings as it does in resource-rich settings, provided it's done appropriately. And so this was an outcome that we wanted to replicate in Africa. We had started working in Botswana and Southern Africa in 1999. And as has been described by Dr. Kilmarks, Botswana has been a particularly receptive environment for international collaboration because of the leadership of President Moai and his government. This is excerpted from the New York Times, and it says, "No country in the world has been struck as hard by the AIDS epidemic as Botswana, an arid, thinly populated land in southern Africa. An astonishing 39% of the adult population is infected with HIV, prompting President Moai to warn, quote, 'We are threatened with extinction.'" I think at the time he uttered these words, some thought that this was some hyperbole, but in fact, this is a real issue for entire societies and cultures across Africa, and particularly southern Africa today. Well, in 2001, shortly after opening the clinic in Romania, we proposed to the Minister of Health of Botswana, Joy Pumapi, that we do something similar in Gaborone. We had been working on the campus of the Princess Marina Hospital. I know a number of you in the room are familiar with the campus and its red roofs. For purposes of orientation, the pediatric ward is located just here. The Harvard AIDS Institute lab is right here. You'll hear more about that in just a few minutes. And the Ministry of Health entered into an agreement with Baylor to construct a children's center, and we were given a piece of property right here, and you can see the patch of dirt that was just the beginnings of the children's center that ultimately was constructed on that site. As the center was being constructed, the Princess Marina Hospital allowed us to renovate 3 rooms at the hospital to open a small pediatric clinic, which we named the Bana Clinic. Bana is the Setswana word for children. We also used it as an acronym for Baylor Botswana Antiretroviral Assessment. We trained 1 doctor and 1 nurse. We brought them to Houston and gave them training in pediatric HIV, and they really formed the core of this clinic. We opened the doors and we said, we're opening a clinic for children with HIV, and that became the first place in Botswana where HIV-infected children could receive treatment. And so the very first children in Botswana treated with antiretroviral drugs received treatment in that clinic. And it helped to catalyze the national program for antiretrovirals for children in Botswana, which was the first on the continent. There were about 200 children receiving antiretrovirals in this clinic at the time it closed and the big center opened. This is the Botswana Baylor Children's Clinical Center of Excellence. It opened in June of 2003. It's a 14,000 square foot building. The ground floor is an outpatient clinic. It has 10 examination rooms, 2 procedure rooms, a pharmacy, a small laboratory, and on the second floor there's a large conference facility. This is a very attractive building. It really is state-of-the-art in every way. This is the pharmacy window. You notice we have these animals tacked up on the walls everywhere. These are distractors for the kids so that when they're in the clinic, they're not thinking about the needle that's about to go into their arms, but rather about what kinds of animals are hanging from the ceiling or on the walls, and we even have some down low along the baseboards for the little bitty kids. This is the conference center on the second floor, and this center has become an amazing place. There are physicians and nurses coming from across the continent to learn about the care and treatment of children with HIV, and I really like to think that this center has not only catalyzed expanded access to treatment for children in Gaborone and Botswana, but really is doing so across the continent. And I really have to thank Peter Kilmarks and Botusa for the support that they have provided for the training activities that have occurred in the center. Today, there are 46 full-time professional staff employed by Baylor who work in the center, including just 3 Americans. There was some skepticism initially about whether people would bring their children to the center for testing. There was pervasive stigma at the time. There still is some stigma, of course, but Botswana really spoke with their feet, and more than 4,400 children have been tested for HIV in the center so far. We have an HIV positivity rate of 38%, and today more than 1,400 children are receiving highly active antiretroviral therapy in the center. This is a larger concentration of children on treatment for HIV than in any center in the world. We thought that this was a model that should be replicated in other places because we saw that pediatric treatment really was not happening to any extent in very many locations across the continent. And the concept has been replicated and really has grown very dramatically. A year and a half ago, I brought together a group of people in Houston from across Africa and around the United States to discuss the possibility of developing a children's clinical centers of excellence network, centers located in resource-poor settings that would cooperate with one another for purposes of care and treatment, health professional training, and clinical research. And we established that network and established the bulleted item number 1 as our mission statement. Today, the network includes the center in Constanza, Romania that I've shown you, the center in Gaborone, which you've now seen, a center in Kampala, Uganda, located at the Malago Hospital, which is supported by the CDC and PEPFAR, a center in Benghazi, Libya. You may know about the nosocomial outbreak of pediatric HIV that has occurred at the Al Fatah Children's Hospital in Benghazi, Libya. And then centers that are under construction and scheduled to open on December 1st, World AIDS Day, in Masera, Lesotho and Mbabane, Swaziland, a center under construction in Lilongwe, Malawi on the campus of the Kamuzu General Hospital, which will open in April, center in Bobo Dioulasso, Burkina Faso. This will be the first children's HIV center in West Africa. And just last week, we signed an agreement with the provincial government in Yunnan province in China to build a center in Kunming, the capital city of Yunnan province in southern China. If a picture is worth 1,000 words, this one definitely says what needs to be said. This is the waiting room of the small clinic that we work out of at the Malago Hospital in Kampala. This is on an average day. I didn't pick any particular day to shoot this photograph. This clinic currently is seeing about 200 children on an average day, and so the needs really are enormous. This is a very small but very functional facility and that's doing incredible work. The antiretroviral program at that clinic started just in January of this year, funded by CDC and PEPFAR. And at a time when enormous numbers of children are coming into the clinic for care, look what has happened just between the first quarter of this year and the second quarter with respect to the number of hospitalizations and the number of deaths. I mean, I would have anticipated a transient increase in both, but in fact, both have declined just from the first quarter to the second quarter. Again, antiretroviral therapy works if it's given appropriately. The Malago Hospital and the government of Uganda actually have dedicated this last piece of open land on the Malago Hospital campus for the construction of a center like the one in Botswana, and we anticipate that construction will start just within the next 4 to 6 weeks. This is our center in Masera, Lesotho, which will be dedicated on December 1st. As you can see, it's almost complete. All of these centers are modeled after the Botswana footprint. This is the center in Mbabane, Swaziland. It's located about 2 kilometers from the Mbabane Government Hospital. All of these centers are built as collaborations between Baylor and the governments. Again, this is after the Botswana model. These are true collaborative relationships. Here's the center in Lilongwe under construction. This photograph was just shot yesterday, and you can see that construction is proceeding along nicely there. And this is the piece of property in Burkina Faso that the government has donated for the construction of the center. So by the middle part of 2006, there will be children's centers modeled after the Botswana Center in 6 locations in sub-Saharan Africa as well as in Benghazi, Libya. Well, as infrastructure has been built, it has exacerbated the relative lack of health professional capabilities in pediatrics in particular. There are a number of contributing factors to this. I've mentioned the low productive capacity of African professional schools, an exodus of African professionals, deaths of professionals, and the crushing burden of care and treatment that is imposed by HIV, AIDS, and other diseases. If you try to quantify this, in a study in 2004 published out of the University of Michigan, it was determined that there were 106 pediatricians in the United States for every 100,000 children less than 15 years of age. But look at the figures for these other countries. And these are data, I took government figures for how many pediatricians were working in country and World Health Organization data for how many children under 15 years of age there are in each of the countries. In Botswana, 2.5 pediatricians per 100,000 children. Swaziland, 0.6, Lesotho, 0.4, Malawi, 0.2. The absolute numbers are astounding. Swaziland currently has 1 pediatrician. Lesotho has 3, Malawi has 13. Botswana is relatively resource-rich with 25. So something has to be done to supplement the pediatric capacity or children will not receive the care that they need. The Pediatric AIDS Corps was announced on June 27, 2005. This is a collaborative 5-year program co-funded by the Bristol-Myers Squibb Foundation. They contributed $22 million, and Baylor College of Medicine, which has contributed $10 million to the program. Our goal in the first year is to recruit 50 board-eligible or board-certified pediatricians or internal medicine pediatric specialists for placement in Africa, either in these centers of excellence that I've described to you or in facilities that are associated with the centers of excellence. So in Botswana, for example, some of the doctors will be working out of the center of excellence, but others might be based in Francistown or Bobonong or in other locations where scale-up of pediatric treatment is occurring. We're requiring a minimum 1-year commitment from the doctors. They will receive training in tropical medicine and HIV before they go. They receive a living stipend, a housing allowance, and student loan debt repayment because student loan debt is an important barrier to doctors traveling to Africa. Our goal is to provide primary pediatric and HIV/AIDS care and treatment directly to at least 80,000 African children over the next 5 years. And these doctors will also be involved in training local professionals to build local capacity that ultimately will replace the AIDS Corps members. It's not our intention for the AIDS Corps to be a permanent fixture in Africa. So far, 35 physicians have been recruited. It's been amazing to see the pool of talent that is out there, people who were available to work in Africa and who wanted to work in Africa but had not had really a way to do that. And it really has been gratifying not just to see the volume of applications but the quality of the applications. And recruitment is continuing, so if you know people who are completing pediatrics training or pediatric infectious disease training who might be interested, please point them my way. Now finally, with regards to research, I will have to tell you very directly that research has not been the principal focus of our network to date. Care and treatment has been the focus. I sometimes say African children with HIV are not dying for lack of access to research. But having said that, we do believe strongly in research, and we believe that the network is on the cusp of playing an important role in advancing pediatric treatment, and that can be done through clinical research, and so we very much welcome collaborative partnerships in research through the network. The prerequisites for this research are that it must be high impact and high quality, it must be ethically unassailable, it has to be locally relevant, and it must advance care and treatment objectives. Now, we have done quite a lot of research through the network already. All of these projects have been done with fellows through our Fogarty-funded AIDS International Training and Research Program. We've looked at operational aspects of pediatric HIV in Romania and Botswana, hepatitis B co-infection in Romania, where 3/4 of the HIV-infected children are also infected with hepatitis B. We've looked at cost-benefit of strategies to prevent HIV vertical transmission in Romania, studies of oral complications of AIDS in Romania. We developed a weight-based antiretroviral dosing scheme for children in Romania, Botswana, and Uganda to substitute for the body surface area-based dosing that's used for several of the medications in children. And probably the most significant trial is the BANA trial, which is ongoing in Botswana, that ultimately will enroll 600 children in a comparison of standard highly active antiretroviral therapy versus CD4-guided intermittent therapy. And there are about 240 children enrolled in that trial so far at the Center of Excellence in Gaborone. The Bristol-Myers Squibb Foundation has funded many of the centers that I've described and many of the activities. The Abbott Fund is providing funding for the network and for the center in Malawi. Again, I want to thank the Centers for Disease Control and Prevention, particularly in Botswana and Uganda, for their support. The Fogarty International Center, our AIDS International Training and Research Program, really has been key to allow us to train local professionals in research. And Janet Butel, the director of the Baylor Center for AIDS Research, I'd like to thank for establishing the international core at Baylor and for allowing us to promote the research activities of the network. If any of you would like to contact me, there's my contact information, and I refer you also to the website for additional information. Thank you.
The question is to Donnie Kailathe. You've been involved in the national program rollout from the very beginning, and I know you've been invited as a guest to a number of other African countries to share your experience. And I wonder what your thoughts are on the use of the Botswana model and its relevance to, or what role it might have or should have in approaches in other African countries. There are obviously a number of different potential approaches, and what your thoughts are on that.
The use of the Botswana model is something that can be extended to other African countries. It's just unfortunate that in a lot of African countries, central healthcare is not centralized. We have different partners coming in and setting their little clinic in one corner, Baylor there, Harvard there. But for Botswana, it's different because all partners or interested partners and all funding is channeled through the government coffers. And it is from those coffers that funds are equitably distributed. Until most African countries can follow that model, where all funding is channeled through a central place before being distributed, it may be a little bit difficult. That also says in terms of standardization, because each training institution has its own specialty. And there are training modules, there may be a lot of duplication, and each one may want to push their cause in a different way. So I think from that angle, Botswana is different.
Mark, your work is really inspiring. I thought when I first heard about what you were doing that we just needed to clone you, and we could really get HIV care set up for adults and kids all over the world. But now I see how far you've progressed in the past year. We probably don't need to clone you. Just wait and see how far you can go. And I wondered if you'd share with us what have been your 3 most important strategies in achieving such a rapid expansion of these pediatric programs.
Well, thanks for your kind comments. I think partnership is key, probably the single key element, partnerships with government. We're not about developing parallel systems or competing programs in any way. We need to be integrated into the programs that have been developed by government. As I mentioned, all of the centers operate under agreements that clearly stipulate the roles and responsibilities of the partners and what the contributions of the partners will be. And these are living documents. They can be revised over time, but you have to at least have a framework to get started. So I think that really has been very much key. I think building local capacity is essential. I didn't have time in my presentation to talk about some of the efforts in that regard, but we're trying some creative strategies to draw professionals back into these settings to work. And so all of the directors of the centers are local professionals. There are no Americans directing any of the centers that I mentioned. They're all local professionals. One of whom, Edith Mohapi in Lesotho, was actually, grew up in Lesotho, left for university and medical training in England, and then came to the United States and is an American board-certified pediatrician who's been working at Georgetown University for the past 20 years, directing outpatient pediatrics at one of their teaching affiliates. We were actually able to recruit her and to send her back to Lesotho to work. We've advertised in South African newspapers and international newspapers. The ad we placed several weeks ago actually said, "Citizens of Malawi, Swaziland, and Lesotho come home to address a critical health care crisis." And we listed the kinds of professionals we were looking for, and in 2 weeks we've gotten 570 applications for jobs at the centers. So we have to be a little bit creative at reducing or reversing this brain drain that has occurred. I think really people have become the rate-limiting aspect of scaling up care and treatment.
Yes. My question, my name is Muhammad Mukhtar, and I am from Thomas Jefferson University. And my question is also for Mark, wonderful work. Do we, I mean, if we, the data which you presented, if you compare the excess of heart compared to the people who are having this problem, so is there any general formula which is followed over there that which kids will get the heart and the other one who won't get it? I mean, you know.
So you're asking specifically about criteria for heart in children, or?
Yes, yes.
Yeah.
I mean, if
Yeah, you know, each country has its own treatment guidelines, and of course there are WHO guidelines and there are country guidelines that generally are run in parallel, and we follow local guidelines for the most part. We'd like to have input into those and to help where we can. But again, we're working in partnership with the governments, and so in Botswana, we respect the local guidelines that are established by the government committees, and that's true in all of the countries, really.